go ahead and get started. We're here with Thursdays at 3, program brought to you by Margin. Margin is part of the formerly Matt Jensen marketing company, now called Men Join Make. And Margin is the practice consulting arm of that business. The idea behind the word margin is that just like margin from a finance standpoint, we need to create space for growth. And I'm here with my friend Arsen to talk about interventional glaucoma. We make sure that we talk about interventional glaucoma at least once every month because it's such a large part of what we're trying to do of the future. I mean, we're seeing uh, you know, with the amount of cataract surgeries that we see every single year, there's more than 5 times the amount of surgery we should be doing in glaucoma because of its prevalence. And it's a sight-stealing disease. And yet, we're not intervening at the rate that perhaps we should. And our first-line therapy is a little bit frustrating because it's not as reliable as we think it should be. And so today we're going to be talking about not only interventional glaucoma, why it's important for practices to consider, but from a business standpoint, can a practice even make it doing interventional glaucoma? Now, I mentioned that I'm joined here by my friend Arsen. Arsen Grigoryan and I have been colleagues and friends for a long time. He is in Southern California at Harvard Eye Associates, which you might normally try to find in the Northeast, but Harvard is in Southern Cal. And he's been the chief operating officer there for quite some time, but really his claim to fame is that he grew up through nearly every role in that organization, knows it inside and out. And so because of that, really has a nice way of getting to implementation. So Arsen, maybe before we get started, I'll have you just tell us a little bit about your practice and about yourself.
Well, thank you, Matt, first and foremost, for inviting me here to speak on this podcast and share our thoughts with colleagues in the area as well. As you mentioned, I kind of grew up here with the company at Harvard Eye. I've been with the organization for 13 years, and I've seen it more than double in size. So we've got 3 locations. Our flagship location is 28,000 square feet. We have nearly 20 doctors taking care of our patients, and we see upwards of 100,000 patients annually. So we are entrusted with the care of a large number of folks in our community, and we take pride in taking care of them. And the organization as a whole, we've been around for over 50 years. We actually celebrated our 50-year anniversary just last year, and we look forward to another 50 years to come ahead of us.
Well, you're 50 years old. Time to get your pressure checked, Arsen. Good. Right on theme with our talk today. I just want to remind people of our upcoming sessions. We're doing this every single week. We do it to try to help other practices grow. I found when I was the CEO of a large ophthalmology group in the Upper Mid and Mountain West, there wasn't a clear place to go with my questions, and especially on implementation. And so today's session, like the ones before it, and the one we're having next week, is to really help practices learn the art of the implementation. So next week, we'll be joined by Liana Miller. She's the Director of Communications for the Refractive Surgery Council and runs a little PR firm called Engage Communications. And we're going to be getting kind of a market update. Is LASIK dead or not? Refractive messages that resonates, because she has her fingers in every market in the country to see what's working where. And I think that's going to be a powerful session. Now, the last plug I'll give here is the next week, the October 3rd through 5th, we have a session in Chicago called The Business of Refractive Cataract Surgery. And the doctors and teams that go to this increase their adoption of premium because of the tools that are provided there, in the teens of percentages. And so really good time to bring your team to Chicago to go through. This is put on by the ASOA and ASCRS, a ton of great faculty, many of whom have been presenters on this session, and a way to learn how to get even more from your premium IOL program, which is one of the more difficult things to implement in a practice today. And so with that, Arsen, let's get to the topic at hand, which is interventional glaucoma. So first, I just want to ask, why interventional glaucoma? Why did your practice feel like they needed to be on the cutting edge of this new technology, and why now?
Good question. But quite frankly, we started in terms of mindset many years ago. It was as early as when I first joined the company 13 years ago. We were talking about it, and our belief system for a long time has been that we want to take the best care of our patients. And we recognized both then and now that drops are not the best option. So then we began to explore what other options, what is there another methodology that we can implement that can help better take care of our patients. And of course, back then we had lasers. Now we've got more options beyond lasers. Of course, the iDose is a huge element of interventional glaucoma. But one of the reasons why we led with this is because we first and foremost believe in taking the best care of our patients. But beyond taking care of our patients, which is the primary goal, we focused on financials as well as operational logistics as well. And when all of those boxes began to get checked, we realized that we have to make a more concerted effort towards making that shift. But we were also looking to see what tools are out there. And even though we had these thoughts in the backs of our minds for a long time, for a long period of time, the tools were limited. And as technology progressed and newer technologies came out, like the iDose, we said, well, this is what we've been looking for a long time. And we were able to start championing the process there. And we also recognized in the process that it's not only significantly beneficial for the patients, but also on the financial side, it helps the organization and gives us additional resources to further take care of more patients.
Yeah, I think the technology really bodes well for a lot of people getting involved, right? We can finally do some of the things that we've wished that drop therapies would do, but we can do it more reliably. I mean, listen, the chemistry behind some of these drops are impressive, right? But there's a lot of question marks once the patient leaves the doctor's office. It's do they actually fill the script in the first place? It can be expensive because sometimes insurance will only pay a portion of it, or because they're recommending a brand name. They may fulfill it that day, but will they fulfill it the next time? So there's an opportunity for fall off. There can be adverse effects from the drops itself, and they're also taking drops a lot of times with a myriad of other drops. And so it can be confusing between which one is daily, which one is 3 times a day. And because of that, compliance gets driven all the way down to basically, way less than 50-50. And so interventions become really important to say, okay, we're going to manage your disease in a more interventional way, and then use drops as a bridge to the next intervention whenever that might need to happen. And for a practice leader, that's so encouraging to me, because I know, I mean, maybe I'll just ask you, how much time do you think any given technician in your practice spends trying to chase down drop details for patients?
That's a good question. I both know from personal experience as well as now being able to speak with my team members, and that can be a very time-consuming process. And when patients call in, you mentioned a wide variety of concerns that they may have that would result in non-compliance. But from a staffing perspective, it's a very time-consuming process to either try and do those refills or pursue those prior authorizations. And there are even moments anecdotally where patients run out early, and it's not because they want to run out early. It's just when they're trying to put the drop in their eyes, instead of one drop coming out, it shoots like a squirt gun. And when they run out after 20 days and they try and go back and refill it, and the pharmacy denies it, they're then calling our office trying to figure out solutions for it as well. And our hearts go out to them, but there are restrictions as far as how often they can refill it. And so then we have to try and figure out how best can we take care of these patients. And so anytime a patient calls our office, it's time consuming, not only for the technician who has to go about executing on that task to make sure the patient's taken care of, but those tasks often go through a series of different channels to get to the appropriate tech. So that oftentimes it starts at the call center, results in a task being created, being sent electronically over to our technicians reviewing it, and then being able to understand clearly what the request is, if necessary, getting guidance from the provider, which takes provider time, and then trying to not only reach out to the pharmacy, but sometimes reach out to the insurance payer, and then call the patient back as well to keep them informed. One of the things that I've always told my staff members is that if we don't communicate with patients, then that can in and of itself cause frustrations for the patients, because they may call and express what their concerns are, but not everything can be done within a matter of a few minutes. Because if you're going through the insurance to get a prior auth, sometimes the patient doesn't know that you're putting in that effort. So then it could be a poor reflection on you if you don't hear, if the patient doesn't hear from our practice. So that's where an additional phone call has to be placed by our staff member to let the patient know, we received your message, we started the process, we did everything on our end. Now we got to wait 3, sometimes 5 business days for the insurance to let us know whether the prior authorization goes through. And so there are so many different touch points that arise as a result of one concern that the patient may have. And that patient may not only have one concern, they may have multiple concerns. They may call back for symptoms or other reasons as well. So that's where we recognize that one patient being prescribed a medicine, it may seem something that is easy to do, because from a physician's perspective, you may think, am I taking the best care of my patient by writing them a script, sending them to the pharmacy? But then when you realize the cascading series of effects that arise after the patient walks out of the office, it actually ends up not only being detrimental to the patient's well-being, but also it begins to consume a significant amount of resources from the company just to take care of one patient. And that can then bog you down and prevent you from taking care of other patients who need equal amount of care for their disease.
Well, and by the way, I love the way you just described that because it sounds so overwhelming, right? And there's so many opportunities to blow it without a call back or without hearing back from the insurance, or so many different concerns, leaving messages back and forth, and a lot of opportunities to frustrate the patient. But even in the most ideal world, when everything is being responded to quickly and we're answering the questions that a patient might have, there's still a significant amount of friction and traction that has to happen, with the goal being that we're going to get that information to the patient who may not comply with it when they finally get it. Creating this very, like, back into this, it's like this unholy cycle of frustration. And you can't bill for all that extra work. The patient doesn't appreciate the extra work. And the output of it is something they probably, I mean, if the data is correct, they will fall off in their adherence to, when it's all said and done. It's just really, this is our best. And so you mentioned iDose. There's other good technologies out there that are procedural pharmaceuticals. There's lasers that are nice first-line therapies. And when I say first-line therapies, I mean you don't have to fail a therapy. You don't have to prove that drops didn't work before you go and do these procedures. I think it's the most undertold story in ophthalmology right now, and especially as practices are trying to figure out how they're going to, understand or make their books make sense financially, is, you've got all these patients who are ocular hypertension or are mild or moderate, who you still have on drops. Maybe it's time for a more surgical or procedural approach. And so I want to use my little tribe there to move to what you've actually done, because you not only use a lot of technologies for interventional glaucoma, but you also have a good way of communicating with patients, getting them in, and pursuing them. Tell us about your flow within the practice. Where do you find your patients who are good candidates for interventional glaucoma procedures?
Good question, Matt. So we have taken a multi-pronged approach. One of the tried and true methods is knowing your patients as they come in, knowing what to look out for. That is the more of the low-tech approach to take. As the provider sees the patients, based on the findings, the diagnoses, so on and so forth, making sure that your doctor, one, is a firm believer in interventional glaucoma, but also being able to educate them. But to me, that's very much far downstream. There are a lot of things that we do upstream as well, and technologies that we use too. So as far as upstream, what we like to do is educate the patients well in advance of them even stepping a foot within our organization. And that starts with when they're booking an appointment. Oftentimes, we know the nature of why they're looking to come in, whether it is for glaucoma evaluation, at times it's for a tension check. So our systems are smart enough to know based on the reason for why they're looking to come in, we can tie in videos and send that to them well before they step a foot. And that's pre-education. But also when they call our patient support center, and I oftentimes have an enduring name for each of our different departments. So our patient support center, I call them the voice of Harvard Eye. They're the first voice that the patients hear when the patients call our department. So I want them to be caring. I want them to be empathetic. But I also want them to be in the best position and have the right tools at their resources to be able to engage with these patients in a meaningful way. And that's where we do provide scripting to our team members. Now, when it comes to scripting, you got to be careful because if folks are too scripted, they sound robotic. So I want my team members to have an organic conversation with the patients, but have guardrails around them as well. And what the scripting does is it actually educates our staff members who may otherwise not live in a clinic, not necessarily know the ins and outs of every pathology. And at times, we're all human beings, we forget, right? You might have been taught something, but if you don't use it for quite some time, you may forget. But by having that scripting on hand, it allows our team members to know how they can share meaningful information with our patients without overstepping, because you don't want to accidentally mislead them. So by giving the patients a wealth of knowledge, when they then come into our office, they engage with our front desk. I call them the face of Harvard Eye. But obviously, there's a beautiful journey they go through there as well. And along each of those different touch points, I want the patient to be further educated, and the experience matters a great deal. But as far as to answer your question, how do we identify those patients? It is in large part by educating them, but also not only organically finding them within our organization, we also leverage technologies. One of the technologies that's been quite helpful to us, quite frankly, has been Brevium. They have these beautiful reports that are generated, and it takes the burden off the administrators. Folks like me who, when I'm trying to think of how do we hunt down these patients and find them, because I want to take better care of them, right? I want to run towards them with a warm embrace, but I got to know who to give that embrace to. That's what the Brevium IG reports do for us. It essentially breaks down the patients. It reads your database. It brings forth the patients who are diagnosed with specific glaucoma-based codes. Then it goes further to filter that based on the payers. Depending on the strategic approach you as a company want to take, you may want to focus on certain payers first to test them out. But then beyond that, it tells you, were there other tried methods that had been done before? So patients who might have previously benefit from an SLT, or maybe there was another procedural pharmaceutical that they had done, and they're probably at the tail end of that treatment, and that same treatment can't be done again, possibly. Then you can say, well, those patients could be some prime group of patients we can focus on, because they're used to having that type of technology be used for the care of their eyes. So there's
So when you've got this
ways.
database, sorry to interrupt you, Arsen, but you've got this database of patients then, and that you're helping filter them. Do they receive different messages based on what they've already had?
They do. So when we identify the patients, we look to see, are they brand new patients to our organization? Are they patients that have been established for quite some time? And what type of treatment have they had in the past? So depending on what the report gives us, we're able to tailor specific videos to those outreach campaigns. So then we can put pertinent information in front of the right patients. So that way it's not essentially a wide approach. We're not using a wide paintbrush, but rather taking a more strategic surgical approach towards these patients and giving them what they're essentially needing.
And when you do that, then, so they come in, then let's say they, do that pre-education. Are they prompted to come in for a consultation then, or what's the next step?
Good question. So it's a combination. So some of these patients already have an appointment to come in to see us. And so by pre-educating them, when they come in, they're the ones asking about the different developments. Because some of our patients, they're so accustomed to being on drops or having a certain treatment option that they don't realize that there are other options that they could qualify for. So
Mm,
instead of having them hear about that the very first time they're sitting across from the doctor, which might be a lot of information for them to try and absorb. And we even know from studies that whether it's patients or patients even with their loved ones, they don't retain 100% of that information, and you can't blame them.
yeah, it's much less.
Yeah,
Yeah,
there's just so much information being thrown at them. But if we can break that up and introduce it to them in a piecemeal fashion, then they can see it, digest it, see it again, and internalize it, and then be able to ask meaningful questions to the doctor, while the doctor could still bring those offerings up. We now have switched the dialogue where the patient says, "Hey, doctor, I saw that video. Could you tell a little bit more about the SLT or the iDose?" And that
mm,
makes it a beautiful way for that conversation to evolve, versus if we're presenting it and asserting it, then it may appear more like a sales pitch. And we want to
sure.
maintain the trust of the patient throughout the entire process.
I want to ask you a question because it's the headline of our conversation today, which is about, does it pay? I've said that the IG space is the most righteous offering in ophthalmology today that pays,
Yeah.
right? Righteous because it fights a sight-stealing disease that we all think we're managing, but might not be, right? And then that it gets some decent reimbursements, at least at current state. Give me a sense of, and you don't have to go into any details or any procedures specifically, but talk to me about why IG is good also from a business standpoint.
A good question. So the best way I can define IG that'll probably be impactful for our industry collectively would be, I often say that IG is doing for glaucoma what premium lenses did for cataracts. So not only is it financially beneficial for the organization, it gives folks something that we did not historically have. And it is a far better approach towards taking care of that pathology. So us as an organization, as I mentioned earlier, we've been deep believers of IG. And on a financial side, we've run assessments as well. And it not only benefits us financially, but it also benefits us through business development as well. Because to me, one of the best ways to get ahead as a business is doing things that one sets you apart. So a differentiator. And some of the early adopters, especially a technology that is extremely effective, it becomes noticed. And a lot of our patients are not only noticing, but they're quite frankly bragging about it as well, which I love. And a lot of our patients, they talk amongst themselves. And I even have anecdotal stories where I was at a gala, and unbeknownst to me, the woman sitting next to me happened to be a patient, and she asked me to talk about our practice and what I did, and I mentioned it, and I was being a bit cryptic because we were at a dinner, and she finally said, "Arsen, where do you work?" And as soon as I mentioned, her face lit up, and she told me that she knew our doctors, and she's told me that she has personally spoken with so many different of her friends and neighbors based on the services that we had offered her. And when a patient who has glaucoma, they have significant symptoms and concerns, and when they suddenly don't have to use drops or have to use less drops, it becomes a topic of conversation. They speak with their neighbors, and their neighbors often say, "Well, what doctor are you going to?" So we found that it actually helps drive more business into our
Sure.
organization. So not only does it bring our new patient numbers up, but it also, from a financial perspective, helps us in terms of reimbursement, and it also helps cut down on the labor costs as well, because there are certain things that we have to do for patients who are solely on drops that we now don't have to do, and we can reallocate that attention towards taking care of more patients.
I'd like to just talk about things that are not office-based for a second. Everybody understands some of the reimbursement as it relates to SLT lasers, right? So that aside, when we're doing a procedural pharmaceutical or any kind of other, MIGS device or things like that, I basically say, or I've heard people say that it reimburses about like cataract surgery or maybe a little better when it's all said and done. Now, that's not an effective complete blanket statement, but as a rule of thumb, I like to back of napkin a lot of things. And a lot of doctors would never give up their standard cataract program. And I think considering this is, can be adjunctive to that, um, from a profitability standpoint, that's how it might be helpful to kind of shore it up in your mind. And I think we need a lot more doctors doing IG because there's far more patients than we can get to there. Yes, it can be a practice builder. Yes, it can be a way to endear yourself to referring optometry and others, so you can intervene on their patients and then get them back for their ongoing, bridge therapies, et cetera. But it also, can be something that keeps your practice healthy. The last thing I'll just say about that is that one of the things we found after visiting practices like yours, and a few others, because I know you all have done kind of a self-assessment, is that patients are twice as likely to be lost to follow-up if they're solely on a drop therapy, right? And so just think about that for a second. Drop therapies are already kind of unreliable as far as their effectiveness, not because the chemistry doesn't work, but because the humans don't work. We're not taking them, or we're not refilling them, or we're uncomfortable, or so on and so forth. And the doctor and team feel like that patient is kind of being managed because we put them on this great therapy.
Mhm.
Meanwhile, if that's the only therapy they're on, they don't feel a ton of ownership and association with the provider who gave them that drop. Whereas if they have some kind of procedural intervention, they're like, that is my glaucoma doctor. They stay. And they're twice as likely to leave if they're drops only. And I find that to be wildly compelling. So it's like it adds insult to injury. Not only are they in a drop therapy that makes them think they're being, that their disease is being managed, but they're more likely to maybe go to other doctors or just be lost in the system, feeling like they're okay. And now we don't have them on our list anymore, et cetera. And for a sight-stealing disease, I think that's terrifying. Arsen, I just wanted to give us an opportunity to, I know Bill and Dylan are on the line. Any questions from our audience? If not, Arsen, I'd like to, or Bill, do you have one?
Not at present. It's something that we're trying to implement, and we're trying to we're busy as we stand currently. I would personally love to try to integrate it into our group, but it's a bit. I have a couple of doctors who are pretty gung ho about it, and others who are on the fence about it. This is really good information, though. I appreciate you guys taking the time.
Oh, our pleasure. And if you ever have any questions, I know Arsen or myself are good people to ask. More Arsen than myself because I'm now an armchair quarterback. But
I was going to say arson over you, but I have a little bit. I have a modicum of I don't know, couth.
yeah, good, good, good. The one thing I just want to give you the opportunity to do, Arsen, is that one, I know you do a lot of teaching on this, right? And you're going to be helping with some boot camps this and next year on how to implement IG in the practice. But for somebody just starting out, maybe leave us with a pearl on what's the best first step for somebody considering doing IG from an administrator standpoint.
Good question. I'd say the best thing to do is start slow. Don't let yourself get overwhelmed, because the thought process of trying to change multiple different things could be very overwhelming. You don't need to conquer everything on day one. So I would start with baby steps. Start by having conversations with your doctors to get their buy-in. If you have their buy-in, then start speaking with some of your team members as well to get alignment. But then find a handful of patients. It does not have to be an extensive system that you put in place on day one. It's easy to find a handful of patients. Start with them and bring them in and start that conversation with the patients. And as you go through it, you'll also learn from your own experiences what's working, what's not. While we can look at the golden standard of what's worked at other practices, sometimes it's also best to try it within your individual practices to see within your region, how are your patients responding to how you're engaging with them? And before you know it, that feedback that you get from the providers, from the patients, as well as the financial reimbursement, becomes that positive feedback that allows you to gain momentum. And you'll start from maybe 2 patients, find yourself doing 4 patients. Next thing you know, it'll exponentially grow, and you'll see yourself doing hundreds of patients and be proud of it.
Well, and I want to just key off of that and say one more thing further. I think that when you compared this to refractive cataract surgery, I think you were spot on. I think that we're gonna, and by the way, like LASIK surgery, in that we used to have coordinators, refractive coordinators who would never let us, lose a lead. Well, perhaps we should have IG coordinators who never let us lose a patient to follow up. There's somebody out there whose disease is progressing towards blindness, right? And we don't have to worry about it being, it's not a loss leader. And even if it was, it would be worth it, but it's not. It's also good for the practice. So I think some of these things, these tools we've had in past lives in ophthalmology will serve us well in how we address IG at our practice. I want to thank you, Arsen, for being part of today's discussion. It's always good to have you. I know it's an abbreviated version of all the talks we've had, but it's a good first step, and I look forward to future sessions with you.
Well, thank you, Matt. Thank you for having me.
And thanks everybody for joining. Next week, we'll be talking with Liana Miller about the state of the LASIK market, and tune in to that Thursday at 3 for more on that information. Have a great day.